I'm really excited to have this opportunity to share, talk to you about the integrity tool. So we will jump in. As an overview of what we'll be talking about today, we'll be giving a background on the integrity crisis in medical research, what has been done to date to address this crisis. We'll introduce the IPD integrity tool, so including its key components, and then we're going to have some interaction where we can work through some examples together. Then we're going to talk about how we can deal with potentially untrustworthy studies. And at the end, we should have some time for questions and discussion and talking about future directions. But before we get stuck in, we have got a Slido interactive module, I guess, that we'd like to get you involved with. So if you haven't used it before, you can access this poll by scanning the QR code on your mobile, or you can on your go to the website slido.com and enter in that meeting number there. So we want to know, what is your professional background? You can type in as many different things as you like, just to get an idea of who it is that we're speaking to today. Oh, sports science, that's good. I have a background in sports science as well, so that's very interesting. I can see we've got a few other people typing, so we'll give you a few minutes. Midwifery, epidemiologists, methodologists. Oh, this is really good. We've got quite a variety here. So thanks for those contributions by a statistician. Okay, excellent. So I'll move on in the interest of time. So there is an integrity crisis in medical research. Some people think I'm melodramatic for saying this, but I'll show you these slides and then you can decide for yourself what you think. So in 2023 alone, we had more than 10,000 papers were retracted due to integrity issues. And there we go. And since then, every day there's new high-profile cases of integrity issues and fraud and investigations happening. So it's really become quite prolific. And estimates vary, but experts estimate that about 20% of research may be affected by research misconduct. So really quite alarming to stop and think, wow, this is 1 in 5 studies that we're reading could be affected by research misconduct. So, and then it's not just sort of media hype, when you actually ask the researchers themselves about misconduct, this meta-analysis of 21 different surveys found that actually 2% of scientists admitted to having fabricated or falsified data at least once, and 34% admitted to engaging in questionable research practices. So this is things like data dredging, conducting inappropriate analyses, and so on. And it gets worse. When asked about the behaviour of their colleagues, these estimates increased to 14% and 72% respectively. And these are likely underestimates. So if we think about the consequences of this untrustworthy research, we can consider it to be a pollutant. And this is flowing into our river of evidence, which then goes on to inform our guidelines, our policy, and our treatment decisions. And as a consequence, can harm patients. And this is demonstrated in this example here of ivermectin for the treatment of COVID. So a few years back, millions of COVID patients globally were administered the drug ivermectin, and this was based on a review of 12 studies, which showed that it could increase survival by a massive 51%. So, of course, there's quite a lot of excitement about this result. However, when the raw, and I should say that was based on the published aggregate data, but later raw data became available, or the individual participant data, and it turns out that a lot of the evidence underpinning this was fraudulent or had major integrity issues, and when they were excluded from the analysis, there was no longer any effect on survival in these patients. So what we have here is we've got patients being administered a drug without any benefit, but with known side effects. This led to shortages of ivermectin for other approved uses. It's generating public mistrust in science, and it's a waste of resources which could have been redirected elsewhere. So I'll hand over to Lena for another example here now of the potential consequences.
Yeah, so I think one example that's quite striking that really shows how damaging the effects of fraudulent research can be and how pervasive and live on as what we call zombie facts is the example of autism and vaccination. So in 1998, a study was published in The Lancet linking the MMR vaccine to autism. And you can see in this graph here how this led to a dramatic decrease in vaccinations and thus disease outbreaks all around here. You can see in England, Wales, and Scotland. Now, this study was fraudulent. So this was not based on real research. And this is something that only became known over time and it took until 2010 for the study to be retracted due to misconduct. Now we're in 2025, 15 years later, but vaccine hesitancy persists, as we see for a lot of recent examples around the world. And there's been a striking survey conducted by the University of Pennsylvania that showed that 1 in 4 adults in the US still believe that the MMR vaccine causes autism. So this is a major problem and even infiltrating politicians around the world. Now, another important example to briefly talk about when we talk about the integrity crisis are paper mills or AI-generated contents. And what you can see here on the slide is a Facebook advertisement for co-authorships. Now you can pay 6,000, I think these are Indian rand, to buy yourself a co-authorship across lots of different areas. Now you may think, how much is that? That's 60 euros or 100 Australian dollars. So really quite cheap compared to all the work that we honest researchers put into our publications. And that's very popular with scientists around the world. Often doctors need these kind of authorships to be able to be promoted, but they're actually way too busy doing clinical work. So it's a really easy way to get yourself that promotion without actually producing research. Paper mills are massively rising, and that's also because AI is really helping them to generate content that looks like a normal research article, but actually isn't true at all. So here this graph shows how many studies are suspected to be from paper mills, and that's risen to almost 2% in 2022. Now we know that since 2022, AI has only got way, way better. So I don't know if this graph will be updated soon, Kylie, but I think maybe even more worrying these days. Now, before we plow on, I should briefly define what do we mean by research integrity. And we see research integrity not as this study is wrong and this one's right, but as a continuum. So on the far end of the spectrum, here's worst practice. That's fabrication, falsification, plagiarism, paper mill produced studies that are clearly fake. There's a lot of studies here in the middle that are somewhere on this continuum that have questionable research practices. For example, a study telling you that it was randomized, but actually not using real randomization. Someone mingling with their data a little bit in the end just to get those results over the P hurdle to get them published in a higher journal, and so on and so on. And then there's on the right-hand side here the best practice research. Now, importantly, when we use our tool, we're not trying to figure out intent. Did someone intentionally do something wrong? Is the study fully fake? But instead, what we try to do is we find studies that we think are so seriously flawed in quality that we do not want to add them to our evidence base, no matter what the reason for that. Okay, so that's the crisis. Now, what has been done to date to address this crisis? And it's great to see that there are many emerging tools to assess the integrity of studies once they have been published. So once we have publication, there's checklists such as the track checklist or reappraised that you can use to assess trustworthiness. These tools assess publications, and I just wanted to give you a few examples of the kind of things they look at. They look at things like, has there been a retraction notice? That's an easy one. Has the study been prospectively registered? Does the ethics approval look okay? One really important one is plausibility. If a study recruits 1,000 patients for a rare disease in a few days, likely not real. Anyone who's ever recruited for trials for rare diseases, it's really difficult. Another one is really prolific publication put. Like this is how we imagine the Spanish chemist, Raphael Luke. Sorry, my Spanish is almost a spasm. To look like, who in 2023 was publishing one study every 37 hours. So clearly something going wrong there. So looking over published work by the authors can also really help us detect wrongdoing. Now, you can imagine these tools may be quite time consuming, so you may be happy to hear there's quite a bit of work being done to semi-automate them using artificial intelligence. And just to mention that Cochrane now also flags retractions in central. And retractions are usually enough for us to say study should not be included in the evidence base if it's been retracted. Now, Retraction Watch has also teamed with Crossref to improve visibility of retracted articles. And there's the Retract2Bot, which I quite like the name of, which alerts authors when papers they have cited are retracted. Now, there's a limitation to these tools that we've just gone through, and that's that many integrity issues can actually only be detected when we look at the underlying data, not just the publications alone. What do I mean by raw data or IPD? I mean these kind of data sets. So actually having a row for each participant that's been randomized or that's in the study. And you may think that this example data set looks really normal and great, but I just want to draw your attention here. This is what we call repeated patterns, which has sometimes been found in fraudulent studies in the data sets that looked fine in publications. And then when the data was scrutinized with things like this were found, here you can see actually someone has just copied and pasted participant rows across. So it all starts with a 1940, and then participant 6 starts with that again, and so on. And that's not just single examples where individual participant data has a lot of power. Find this really striking, this example. Now, Kylie is one of the pioneers of integrity research, and he's also editor of the journal Anesthesia. And what he did is he looked at 400 studies in his journal. And first he looked at their publications alone. And you can see in this plot, most of them looked okay and passed all the checks. So just a few were flawed or fatally flawed. Now then he looked at the individual participant data. And what he found was quite shocking. He found that almost half of studies had some serious flaws. You can see here in the yellow. And about a third were so-called zombie trials, fatally flawed studies that you would not want to include in your evidence base. Now, most of these studies look totally fine when looking at publications with these checklists. Now, I started becoming aware of the integrity crisis when I was doing a large individual participant data meta-analysis on co-op management at preterm birth. And because I started becoming aware of that and the power of individual participant data, I decided I wanted to check integrity systematically for this study. Now, what I did most of the time, I had a task or anything difficult to do, really. I asked my then postdoc, who's now team lead Kylie, said, hey, Kylie, can you just find us a tool that assesses the integrity that we can just use for all trials and our individual participant data meta-analysis? What did you say, Kylie?
I said, yes, sure, because I always think Lene has great ideas. And I actually thought it would be relatively straightforward and a matter of just finding an existing checklist or tool. So I was quite surprised, given how much the importance of IPD to detect these integrity issues, I was quite surprised to see that there were no standardized tools for this purpose. So following on from that, began a project which was part of my PhD to develop an IPD integrity tool, and this was to screen randomized controlled trials using IPD. So I think we pause here for a moment with another Slido just to get an idea of if any of you have already used any integrity tools or if there's any that you are familiar with. So Lene showed a few earlier, the TRACT tool and I think the Cochrane pregnancy and childbirth tool. So if anyone has used any, I can see someone is typing here now. So just wait and see. Up here.
None, you can also just tell us that, and that way we know we need to explain a bit more.
Yeah, you could say no, none. Yeah. Mo says a Cochrane editor. That's good. That's very good. So I think from this, we can assume maybe not too many have been used or, yeah, so I think we'll move on. So now we are going to introduce, or you've already heard of it before, tell you more about the individual participant data or IPD integrity tool. So how did we develop it? So we use comprehensive methods, which I won't go through in too much detail, but we did a literature review of existing checks, and we formed an expert advisory group to help refine some checks into an initial tool, which we piloted in several large IPD meta-analyses. And we also did some validation exercises. So we got some data sets that were known to be fraudulent provided to us by some journal editors in confidence. So we were able to conduct some validation, and we also did lots of evaluation and refinement as we went along. So if you want to know more about the methods development, there is a paper in research synthesis methods shown here, which you can check out. Published alongside that paper was the instructions paper. So this goes through step by step. How do I use the tool? How do I apply it? And it's got everything you need there to be able to use it. So what is the tool? And this is sort of what it looks like. So it's a standardized checklist of items for assessing the trustworthiness of RCTs. And so at the top here, we have 3 components of the tool. We have an instructions and decisions guide, a rating sheet, and automation script, which we'll go through in a little bit more detail shortly. And then down the bottom here, we have our domains. So we still have the aggregate data checks here, or the publication level checks, things like ethics and retraction, etc., because these are really essential. And, in an IPD meta-analysis, not everyone provides IPD. So they're very important as well. And that's sort of a unique factor of the tool, that we combine this with these items or domains, which is our key point of difference. So these are focusing on the IPD, looking at things like unusual data patterns, are correlations present that we'd expect, patterns of allocation, inconsistencies, and so on. And again, we'll go through these a bit more in detail. So in terms of instructions, I guess the first key point is, when should I use the tool? And as we mentioned, it was designed in the context of conducting an IPD meta-analysis project. However, there is broader scope for the tool to be applied. So if you look at this table here, many of you may be more commonly conducting aggregate data meta-analysis, and you may have concerns about a study, in which case you can request the IPD. Whether or not that's provided is another question, but so that's another way you can delve deeper. We've also had a lot of interest from journal editors and publishers who are quite concerned about publishing these studies. So they could use the tool at the submission stage, or also if there's a publication that people have flagged as potentially problematic. So there's some of the uses. There may be many more as well. And then our decision guide goes through how to rate each item. So it looks a bit like this. There's a big table in the publication, which essentially has each item, how to assess the item, and some of this is semi-automated, and then how to respond. So you need to rate it based on the instructions here. So quite step-by-step on how to rate each item. And then lastly, you need to make a decision of, do I trust this evidence enough that I want it to contribute to my meta-analysis? And there is a decision tree, which we'll come back to again a bit later, on how to deal with that. So I hand back to Lene now.
Yes, I will now walk you through some of our automation scripts. And you may have asked yourself, wow, that all looks great, but that must be a lot of work. So you'll be happy to hear there is a semi-automated script that does a lot of the work for you. Now, how does it work? So this is in an R Markdown, has quite detailed instructions on what to do. And if you're doing an IFD meta-analysis, it only needs to be set up once, and then it can be run for every study automatically. Otherwise, of course, if you're looking at individual studies, the setup will have to be done for that study manually. Now, what do you need to use this tool? A little bit of basic coding knowledge is advantageous. So really, we try to take most of the coding away from you there, but a little bit would help. And you need to think about which variables you want to pre-specify for the different domains. So, for example, when we're asking are expected variables correlated in your data set, you need to have a think about what these kind of correlations could be. Now, here it shows you a little bit further on the step 4, where you select the different variables. So you basically just replace the green text with your group variable here, for example. So it gives you quite detailed instructions for that. And then I'll show you a little bit of the output this script gives you. So this output here is about the domain correlations. So if do expected variables in your data set correlate. And what we looked at here in children was, do weight and weight for age correlate with each other, which would be expected. And in the output, you can see there's quite a nice correlation. So that would be satisfactory here. And you get also some correlation values in the output. And some questions that help you to kind of make decisions as well here. The next one we have here is looking at patterns of randomization, and that shows you over time which groups were participants randomized to. And if randomization worked well, you would expect the lines to be going kind of up at the same rates, which you can see in this example here. That looks quite fine. Sometimes we see funny things here, like some weeks only participants got randomized into the control group and the next week only in the intervention group, and then we know possibly quasi randomization happened here. There's something going wrong. Another one that works quite nicely is which days participants were randomized in. And actually, we're usually not really looking for uniform distribution here. So if every day the same number of participants were randomized, including on a Saturday and Sunday, you'd often ask some questions unless the randomization had happened, for example, in an emergency unit. Because even in hospitals, research nurses often only work on weekdays and not on the weekends. So trials often recruit a lot less participants on the weekends. So again, you need to know your area of your field a little bit and what would be expected, but often a uniform distribution is actually something that may cause worries. Another test the script does for you automatically is terminal digit bias. And what's that? Now, humans are actually really bad at making up random numbers. So we tend to introduce a lot of bias, and you may want to try that out for yourself, but maybe now I've told you, you'll be good at not introducing that bias. If you just try to write down 20 random numbers, you'll likely end up with having the same terminal digits over and over again. So using lots of 3s in the end or lots of 7s in the end, because that's just how our brains work. So these graphs can help you to disentangle where there's some terminal digits that were used much more than in other ones. And I think here what's also important to remember is that there may be rounding mistakes, or there may be variables that can only be measured with a 0 or 5 in the end, and that's obviously fine. Kylie.
Okay, yes. So we've gone through the decision guide, the automation script, and then of course there's the rating sheet. So just very briefly, just to show you, there's a Excel template where you can indicate your rating and the justification for that rating, to log it all here. And I guess we've already mentioned the retraction watch database, but to do these assessments and ratings, ideally you'd be using trial publications and protocols, trial registration records, and then, of course, the Markdown output that Lene has just gone through. So if we jump back to our case study on ICOM, did it make a difference, us applying this tool? Well, we actually detected 90% of trials that provided IPD had at least one potential integrity issue, which sounds a bit crazy, but a lot of these were minor inconsistencies that we were able to be resolved with the trialist, and so that improved the quality of our data set. We did end up excluding 3 IPD trials with integrity concerns. So one of them, there was a lot of discrepancies between the raw data and the publication. And there was also a lack of association between variables known to be highly correlated. So, and I should mention as well, of course, not all trials provide their IPD, and those that didn't, we also excluded several of those based on our integrity checks. And as you'd expect, a lot of the quality of those is often not as high as the trials that provide data. So now we're going to move on to some detective work. So we have some examples here, and we're going to ask you what you think. So the first one relates to correlations. So here we have the relevant information from the decision table for you to look at to guide your rating. And then we're going to look at are expected correlations present here. So here we have gestational age at birth on the x-axis and birth weight on the y-axis. And I should mention this is preterm infants. So just I'll give you a minute just to look at this and think about how you would rate this item, whether it'd be no issues, some or minor, or many or major. And I'll let you answer that here now in the poll. Sadly, we can't have the correlation, the plot and the poll up at the same time, but hopefully you can remember what you were looking at. Oh, this is good. Oh, I gave away the answer. Okay, so we've got a few people voting many major issues. Okay, well, you are correct. So trial B is the one we were just looking at, and that is actually a real world example. But trial A is obviously what we'd expect. So as an infant or baby is born closer to term, we would expect them to have a higher birth weight. So this study on the right also had several other integrity issues, and we ended up having to exclude it from our meta-analysis. So our next example is with Lene.
Oh, yes. So the next one is in the domain, are there any unusual or repeated data patterns? And we're again talking about the bias in the terminal digits that I already explained earlier. So this whole idea of us being really bad at making up random numbers. So let's have a look at this example. So here we've told our automated script to give us terminal digit bias graphs for diastolic blood pressure, systolic blood pressure, and weight. And you can see, so on the x-axis is what the terminal digit was, so from 0 to 9. And on the y-axis is how many participants had this terminal digit. And I'll let you have a look at this plot and start thinking about, do you think these are no issues, some minor issues, how many major issues? And you can start getting your phones or laptops ready because we're going to ask you via Slido again.
Shall I jump forward?
I think so. I think.
Okay.
Hopefully, I don't through this too quickly. What do people get? How would you rate this item? We'll give people a little bit of time again. So this is interesting because there's people having some different opinions here, right? Very interesting. Great. Thank you all for your responses here. All right. Yeah, seeing almost so people think no issues, some minor, or many major. Quite a few differences here. Excellent. Maybe we'll move on. And I agree with you here. So I would possibly have rated this as no issues because the counts are not that high. So it can happen that in a random distribution with these numbers, it's not fully uniform. But I can also see that some really seem to be a little bit lower here. So I understand why some may have used some minor issues. And you can also see it's not always black and white. But yeah, I would probably have rated this as no issues. How about you, Kylie?
I think I would have as well. Yeah.
Excellent. Great. Now we'll have another example for bias in the terminal digit. This one is birth weight. And again, I'd like you to have a look at this plot. It's a smaller sample, so we actually only have 9 participants here, I think, overall. And I'd like you to have a think about, do you think there's a bias in the terminal digit here, with 8 participants ending with a 0 and 1 ending with a 5? And maybe we jump forward and get you to open your slide.
Oh, I think
Where did it go?
I think something's gone wrong.
Um,
Oh no, here we go. It's being updated.
right. Interesting. So we have a few saying some minor issues, some say many major issues. Great. So this is actually an example where at first you look at this and you think, oh my God, something's gone seriously wrong. It must be a major issue. But then you start thinking about it and you say, well, maybe they had a scale that only rounded to 0 or 5, or maybe it was a questionnaire where they only gave rounded birth weights. So to remember, this is in grams. So I would actually think this is a precision issues in the data rather than an integrity issue. But I do understand why some people would see this maybe as minor concerns. And this is an example where you'd possibly check in with a trialist as well and try to find out more. But we see these quite often, and I think when it ends on 0 and 5 a lot of the time, that's much less of an integrity concern than if it ended on 2 or 4, isn't it, Kylie?
Yeah. Yeah. Okay. So now we're looking at patterns of allocation. So and we're assuming here there's a 1-to-1 randomization allocation. So this plot here, we have time on the x-axis, cumulative count on the y-axis, and so the numbers being allocated to control are shown with the red line, and those allocated to the treatment are in the blue. So I'll give you a moment to contemplate that one, whether you think how you would rate it in terms of whether it has any issues. Hopefully, I know we're kind of rushing things along and you probably want a bit more time, but if you've had enough of a chance, it'd be good to rate this item here. Major issues.
Wow, quite a split, isn't it?
Yeah. Interesting. So this is really, yeah, like Lena said, it's often a gray area. People sort of want it to be straightforward to say, oh, this is definitely an issue or not, but it's not always the case. So, okay, many major issues among most people. So we'll go back to our example. Clearly there is quite a diversion about halfway through. Actually at the start, it looks like most people are getting the control, and then halfway through, all of a sudden, I think maybe they got more treatment available. And so there's a diversion there, which I would rate as an issue. Probably I would say some minor issue, but I can see why people would have said major as well. Something we do need to consider as well is we need to look at, was block randomization used, for instance, and make sure that it is 1-to-1 allocation. So yeah, looking at those sorts of things also important. And the size of the trial too. Another one with randomization here is relating to the day of week, so that Lena mentioned before. So this plot is showing participants allocated to group 1 and group 2 on each day of the week. And I should say for this trial, it's not an urgent intervention. It is just a run-of-the-mill standard, non-urgent intervention. So let's have a look now what people think. Oh, I don't know why it looks like it carries over a bit from the previous poll here. So that's a bit confusing. But
I can track how much it changes.
yeah. I'll let you do that live. But okay.
So I think more people now say no issues or some minor issues than before. Whereas
Yeah.
the major issues, Kylie.
Yeah. Okay. Yeah. Okay. So if we go back to it, I guess it's a little surprising how many are randomized on Saturday and Sunday, given it's a non-urgent intervention. So I think I would call that an issue. Probably some minor issue. What about you, Lena?
Yeah, I agree. And again, I think if this trial had everything else looking perfectly, I wouldn't worry. If there were lots of other flags, then that would maybe be one to add to it. Yeah, so minor.
Yeah. Okay, and I think this is our last example, maybe?
Yes. That's mine, isn't it? So here
Yes.
we are thinking about plausibility. And here we've done something a little bit different. We've given you two examples, and we ask you to say which of them would you rate as questionable. One of them is a twice a week intense exercise intervention where participants are asked to come to a center in the hospital, a little internal gym, twice a week and do exercise. And after 1 year, all but two participants have been to every single intervention. Now, the second example is in hospital mortality, where it's looking at who dies out of 40 patients admitted with COVID-19. And we see no missings at all in this data set after 1 month. And I'd like to know from you, which of these do you think is most questionable? Example 1 was the exercise intervention. Example 2 is the COVID-19 example. Maybe I've made this one too obvious, haven't I, Kylie? Oh no, we've just given such a good webinar that everyone really understands well. So yeah, so I think this is an example to show you that it's really context depending. And then sometimes no missings can be plausible. Usually with a low number of participants in one center, you know who's died and who hasn't. Someone severely ill with COVID-19 is unlikely going to just disappear. Whereas an intense exercise intervention is something that I think most of us know that gyms make money out of all the people that sign up but don't go. So I think this would be something quite similar here. All right. Now that's all of the examples we've brought for you today. And we've already alluded to this a little bit, is once you've gone through all of these different items, you need to make a final decision. What is my study? Is it a trustworthy study, or do I have some questions? Now, there's a few easy ones. For example, we say if there's a retraction watch, you don't even need to run any of these checks. You can exclude the study straight away because even the journal that it's published in has said this evidence should not be in our evidence base. Otherwise, we really differentiate between major and minor issues. Sometimes one really, really major issue can be enough to exclude a trial, where sometimes a few minor ones can be easily resolved and are fine. We do try to check in with trialists as well if we have questions. Some things can be resolved quite easily with them. There's one case though, which we've started considering a lot recently, is sometimes you really have trials in the gray zone. You just don't fully know. And in that case, we actually now recommend to do sensitivity analysis. So any trial that you have serious trustworthiness concerns for, we just remove from the evidence base. We do not want in our meta-analysis or in our journal. But there's some trials where we just don't fully know what's going on. And for those, we're suggesting sensitivity analysis. So to exclude them and see if it changes your conclusion at all. So a few frequently asked questions. We will have a Q&A in just a couple of minutes, but we're already thought we'd cover a few of the questions that we get a lot. So the first one is, but isn't this way too much work? All of what you've presented looks so comprehensive. And actually, once you streamline it, it's pretty quick because so much of it is automated. So it takes us about 30 minutes per trial, similar to what you maybe would spend on risk of bias as well. And we think this is so important. If a study isn't trustworthy, it really just shouldn't be contributing to your review. The other question we get a lot, which we don't have a proper answer for, is, but who would be silly enough to share fake IPD? And I think the simple answer is people do. We have all these examples where they just think we're not going to detect it. I suppose the other answer is we also do look at trials that don't share IPD in their published summary data, but we're already a lot more skeptical of them. And the last question is, how can I access this tool? And we've given you a QR code here that has been published on Research Synthesis Methods. And what we're actually currently doing is we're doing a lot of piloting, refining of the tool. We're doing so we are calling for early adopters. I don't know if early is the right word, Kylie, because I think it's been around long enough. We're looking for adopters that would like to work with us to apply this to their context, because we've mainly been using this tool in child health. So do contact us if you'd like to work together on this and share your experiences with us.
Okay, so now I'm just going to briefly just say, well, what should we do when we identify potentially untrustworthy studies? So as we mentioned, our first port of call is always to contact the authors and say, look, we've noticed this. Do you have an explanation? And often, things can be resolved that way, or often you won't get a response, which is probably a red flag in itself. Also would refer you to Cochrane's policy for managing potentially problematic studies for advice. Someone mentioned PubPeer before, so you can anonymously post any concerns you have about a study on that website. You could contact the journal editor about your concerns, and journal editors do have guidelines from the Committee on Publication Ethics on how to deal with these. You may consider also contacting the institution that led to the study. I'll jump back to our ICOMP case study. So it all ended with 2 publications. Well, it's not ended, but the first impactful thing was that these 2 publications in the Lancet. And following publication of these, there was a letter written and published, which said that we should have published the results of our integrity checks explicitly, which we then counted. So this is an issue of it's a balance of between, we're very supportive of transparency, but we also need to protect our collaborators who have shared their data with us in good faith. And we don't know what their intent was, and it's not a very good way to conduct IPD meta-analyses and ask people to share data and then tell them what the problems with those data. So we would share that information if people request it, but prefer not to publicly disclose it. And lastly, the future direction. So the tool is not intended to be static. We are working to continually update and refine it. So like Lene said, we're doing a lot of piloting and getting feedback on items that maybe can be added or removed or refined. We are working with a digital expert to try and develop a more user-friendly web interface, which hopefully, will be ready for testing soon. We're doing validation. We're also looking at AI-generated data sets and whether the tool can detect these. And we're looking to disseminate more broadly and, of course, continue scoping. So I kind of consider this like akin to doping in sport. The fraudsters are maybe always going to be one step ahead, but so we need to keep scoping and try and keep pace with the latest methods, especially with the rapid advancements in AI. So the IPD tool that is I see that it is a filter. So a filter that's getting rid of the pollution in our evidence. But ideally, we don't want this pollution in the first place. So hopefully in the future, there'll be more education and training around this integrity issues. And I think we need to address the publish or perish culture. So I love this quote from Doug Altman. We need less research, better research, and research done for the right reasons. So we need to incentivize best practice and deter misconduct, support investigative research, and foster self-correction. So there is a lot of stigma around retractions, but sometimes authors do identify a mistake in their own study, and they should be encouraged to come forward and use these as learning opportunities. But at the moment, retraction is not something anyone wants next to their name. Of course, adopt screening tools like our one to detect integrity issues. And we really want to promote open science. So mandatory data sharing, which can help us really check these things. So before we have discussion, I just wanted to acknowledge the team, some of whom are shown here, for all their contributions to the development of the tool. And thank everyone for joining today, and remind you, if you are interested in trying the tool, please do get in touch. And I think this QR code is the publication again.